In this video, we will discuss commonly held 4 myths or misconceptions about prostate cancer. 1. Prostate cancer is often diagnosed at a very late stage. This is incorrect. At the time of diagnosis, 78% of patients have localized cancer. This is completely confined to the prostate and often curable. 12% of patients have regional lymph node involvement. This is locally advanced cancer and could also be curable. 6% of patients have distant metastases. This is often non-curable. 2. Prostate cancer causes waterworks symptoms. This is incorrect. Most prostate cancers cause no symptoms because most cancers grow on the peripheral areas of the prostate, away from the central area where the water pipe passes. Uncommonly, prostate cancer may present with waterworks symptoms, blood in the urine or the sperm. However, waterworks symptoms are more commonly due to benign conditions such as benign prostate hyperplasia rather than to prostate cancer. In metastatic cases, prostate cancer could present with bone pain, blood in the urine, retention of urine, and back pain due to spinal cord compression. 3. Raised PSA is always caused by prostate cancer. This is incorrect. Prostate-specific antigen, or PSA, is a protein produced by normal as well as malignant cells of the prostate gland. The PSA test measures the level of PSA in the blood. For this test, a blood sample is sent to a laboratory for analysis. The results are usually reported as nanograms of PSA per milliliter of blood. PSA is not a very specific test because a lot of patients who do not have prostate cancer could still have a raised PSA. An elevated PSA can occur in several benign conditions. These include transient causes like prostatitis, urinary tract infections, retention and perineal trauma, and persistent causes like prostatic enlargement. 4. Prostate cancer is a deadly disease. This is incorrect. 94% of prostate cancer cases are not deadly, and the patients die with the disease rather than of the disease. 96% of males with localized disease survive 15 years after the initial diagnosis. 6% of prostate cancer could be deadly when there is evidence of metastatic disease. 30% of men with metastatic prostate cancer survive 5 years. 10% of men with metastatic prostate cancer survive 10 years after the initial diagnosis.
Normal PSA. There is no normal PSA cutoff value as such. However, the most commonly quoted study that many urologists base their practice on is that of Osterling et al., which reported the normal PSA values that correspond with different age ranges, as shown in the table here. So for patients between the ages of 40 and 50, the upper limit of the normal value of PSA is 2.5. It's 3.5 for patients between the ages of 50 and 60, 4.5 between the ages of 60 to 70, and 6.5 between 70 and 80. There are several studies which reported the correlation of different ranges of PSA with prostate cancer. Of these, we mentioned the study by Catalona et al., which showed that 26% of patients who have PSA between 4 and 10 have prostate cancer, and 53% of patients with PSA more than 10 have also prostate cancer. Furthermore, the prostate cancer prevention trial, which is a landmark trial, reported a high percentage of prostate cancer in men with PSA less than 4, whereas 25% of such patients were reported to have prostate cancer, which is rather alarming. Moreover, Gerstenblatt et al. Reported on the predictive value of high levels of PSA more than 20 for detecting prostate cancer, and they reported 87% chance of having prostate cancer in patients with PSA levels higher than 20 and 100% chance of having prostate cancer in those with PSA levels higher than 50 nanogram per milliliter.
Here are some common myths about prostate cancer and the facts to dispel them. Myth 1. Prostate cancer only affects older men. Fact. While prostate cancer is more common in men over 50, it can affect younger men as well. Family history and genetic factors may increase the risk, making early screenings important for some men. Myth 2. Prostate cancer always causes symptoms. Fact. prostate cancer is often asymptomatic in its early stages. Many men are diagnosed through routine screenings before they experience any symptoms. Myth 3. A high PSA, prostate-specific antigen, level means you have prostate cancer. Fact: elevated PSA levels can be caused by various factors, including benign prostate enlargement, BPH, prostatitis, or even recent physical activity. It does not necessarily indicate cancer, but further tests may be needed. Myth 4. If no one in my family had prostate cancer, I won't get it. Fact: while a family history of prostate cancer increases risk, many men diagnosed with prostate cancer have no family history. Lifestyle, age, and other factors also play significant roles. Myth 5. Prostate cancer grows quickly and is always life-threatening. Fact: many prostate cancers grow slowly and may not pose a serious health threat. Some men live with prostate cancer for years without requiring treatment. Others may have aggressive forms that need prompt attention. Myth 6. A prostate cancer diagnosis means surgery or radiation is inevitable. Fact: not all prostate cancers require aggressive treatment. Active surveillance or watchful waiting is an option for slow-growing cases. Treatment decisions depend on the cancer stage and the patient's overall health. Myth 7. Prostate cancer is contagious. Fact: prostate cancer is not contagious. It cannot be spread from person to person. Myth 8. Changes in urination always indicate prostate cancer. Fact: while urinary issues can be a symptom, they are more often caused by benign conditions like BPH or prostatitis. Prostate cancer is not the most common cause of these symptoms. Myth 9. Prostate cancer treatment always leads to impotence or incontinence. Fact: while some treatments can affect sexual and urinary function, advancements in technology and techniques, like nerve-sparing surgery, have reduced these risks. Side effects vary by individual and treatment type. Myth 10. If I feel fine, I don't need to worry about prostate cancer. Fact: prostate cancer often develops silently without causing noticeable symptoms. Regular screenings, especially for men over 50 or at higher risk, are crucial for early detection. Dispelling these myths helps in making informed decisions about prostate health and emphasizing the importance of regular checkups. Prostate cancer is the second most common cancer in males worldwide. The current lifetime risk of prostate cancer for males living in the United States is estimated to be approximately 1 in 8. There are 5 widely recognized risk factors for prostate cancer. Number 1 is age. Clinically diagnosed prostate cancer rarely occurs before the age of 40, but the incidence rises rapidly thereafter, peaking between the ages 65 and 74 as shown in this graph. Number 2 is ethnicity. Prostate cancer is more common in Black compared with white or Hispanic males, perhaps related to a combination of dietary and genetic factors. In addition to higher incidence rates, the cancer tends to happen in younger age groups in African American males. Number 3 is family history and genetic factors. Males with a family history of prostate cancer, particularly those with a first-degree relative who was diagnosed at age of less than 65 years, are at increased risk for prostate cancer. Males with a family history of breast cancer are also at a higher risk of prostate cancer. Number 4 is cigarette smoking. Most case control studies have found either an increased risk for prostate cancer or more frequent high-grade prostate cancer and advanced stages in smokers. Smoking appears to have a much larger impact in African American populations. Males with prostate cancer should be strongly encouraged to stop smoking for both health benefits related to prostate cancer and overall health. Number 5 is obesity. Meta-analyses have consistently demonstrated a small but statistically significant association between obesity and prostate cancer incidence. Several studies suggest an apparent relationship between obesity and disease aggressiveness, with an increase in both recurrence rate following treatment and prostate cancer mortality. In this video, we cover the most important dietary elements that have been examined in relation to prostate cancer. Number 1 is animal fat. A diet high in animal fat appears to be associated with increased risk. Foods to avoid are red meat and some dairy products. Number 2 is vegetables. A diet low in vegetables may be another risk factor for prostate cancer. High intake of broccoli and cauliflower seems to be protective against an advanced types of prostate cancer. Number 3 is tomato. Tomato is rich in lycopene, which has a strong antioxidant properties. Lycopene has been associated with a lower incidence of prostate cancer and a decreased risk of lethal prostate cancer. Number 4 is soy. Soy foods contain a type of estrogens, which may reduce prostate cancer risk by decreasing the effect of the male hormone on the prostate. The higher intake of soy products among Asian males has been hypothesized to be one reason for the lower incidence of prostate cancer among these males. Number 5 is omega-3 fatty acids and fish oil. 2 large trials found that high levels of omega-3 fatty acids were associated with an increased risk of clinically significant, high-grade prostate cancer. We continue to cover the most important dietary elements that have been examined in relation to prostate cancer. Coffee. Increasing consumption of coffee appears to be associated with a decreased risk of lethal prostate cancer. Multivitamins. The regular use of multivitamins does not appear to affect the risk of early or localized prostate cancer. However, 2 reports have observed an increased risk of advanced or fatal prostate cancer in males using relatively large amounts of multivitamins. Selenium. This is found in Brazil nuts, for example. One large analysis showed that high blood levels of selenium were associated with a lower risk of aggressive disease. The same analysis showed that higher levels of nail selenium were associated with a decreased incidence of both aggressive and non-aggressive prostate cancer. Zinc. This is found in pumpkin seeds, for example. At least 2 studies have suggested an association between zinc supplement use and an increased risk of prostate cancer. Calcium and vitamin D. In a large analysis, males with the highest intake of calcium were more likely to develop prostate cancer than those with the lowest intake. Studies suggested that there is an increased risk of prostate cancer in males with both the lowest and highest vitamin D levels. Physical activity. Males with high levels of physical activity were less likely to be diagnosed with high-grade prostate cancers. The prostate, a small gland in the male reproductive system, is crucial to overall health, but can cause significant issues when neglected. Prostate cancer is one of the most common cancers among men, with about 200,000 Americans diagnosed each year. 1 in 9 men will develop prostate cancer during their lifetime. Key risk factors for prostate cancer include family history, age, it's most common after age 50, and race, along with other factors like weight and smoking habits. However, the disease can affect men of all backgrounds. Early-stage prostate cancer typically shows no symptoms, but as it progresses, signs may appear. Common symptoms include difficulty urinating, pain during urination, frequent or urgent urination, especially at night, and discomfort when sitting. Some men may also experience pain during ejaculation, erectile issues, or blood in the urine or semen. In more advanced stages, prostate cancer can cause pain in the back, hips, or chest, and numbness in the legs or feet. While these symptoms don't always indicate prostate cancer, they should prompt a visit to a urologist, especially if multiple symptoms occur. Early detection significantly improves outcomes, with a 5-year survival rate of 97% when diagnosed early. To reduce the risk of prostate cancer, men should get regular screenings, especially those at higher risk, maintain a healthy weight, exercise, eat a nutritious diet, and avoid smoking. Early detection through screenings is crucial, as prostate cancer can be treated more effectively when caught before it spreads. You might have heard that symptoms like waking up at night to pee, a weak or interrupted stream, or feeling the need to go urgently could be early signs of prostate cancer. While it's important to pay attention to your health, this idea is mostly a misunderstanding. The truth about prostate symptoms. Common symptoms are usually not cancer. These urinary symptoms are much more likely caused by benign prostate enlargement, which is a normal part of aging, rather than cancer. Prostate cancer usually grows in an area of the prostate that doesn't affect the flow of urine, especially in the early stages. Why the confusion? Many men with prostate cancer also have these symptoms, but not because of the cancer. It's because prostate enlargement and cancer often happen around the same age. What you should do? Don't panic over symptoms. If you're waking up at night to pee or your flow isn't as strong, don't automatically think it's cancer. These are normal changes as you age. However, if these symptoms bother you, see your doctor. They can help treat the issue and check your prostate health. When to check for cancer? If you have a family history of prostate cancer or are concerned, ask your doctor about 2 simple tests. 1. A PSA blood test to check for prostate-specific markers. 2. A digital rectal exam to feel for any unusual changes in the prostate. These tests can help find cancer early when it's easiest to treat. Key facts about prostate cancer. Most cases are silent early on. Early prostate cancer usually doesn't cause symptoms. That's why regular checks are important for those at risk. The good news, about 78% of prostate cancers are caught very early and are treatable. Only a small number of cases, around 6%, are found at a late, more serious stage. Takeaway message: if you have common urinary issues, they're likely not related to cancer, but you should still see your doctor for peace of mind and treatment. For cancer concerns, regular screenings can make all the difference. Thank you for watching.
In this video, we will demonstrate sampling an abnormal area of the prostate using a transperineal approach under local anesthetic. John is a 74-year-old patient who was referred with raised PSA of 14. He had an MRI scan of his prostate, which showed an 11 mm focus of abnormality in the right peripheral zone of the prostate. The peripheral zone is the outermost zone of the prostate close to the rectum. This lesion was reported as Likert 4, which is an MRI score that indicates that the lesion is likely to be cancerous. The score ranges from 1 to 5. 1 and 2 refer to benign lesions. A score of 3 refers to some uncertainty between cancer or inflammation, and score of 4 and 5 indicates a likelihood and a high likelihood of cancer respectively. As you can see in the video, the lesion is first visualized in the cross-sectional view, as you can see here, and subsequently also visualized in the sagittal view, as shown on the right-hand side. Then the local anesthetic is infiltrated, as you can see. The needle is infiltrating the local anesthetic superficial to the pelvic floor muscles. Then the needle goes through the pelvic floor muscles, and then reaches the paraprostatic tissue and the neurovascular bundle, and then the needle is withdrawn. The needle is moved more anteriorly, and more anesthetic is infiltrated to provide an anterior cover. We always twist our probe medially to check that the urethra is safe, and more local anesthetic is infiltrated in the pelvic floor muscles, and the rest is infiltrated on the way out. The access needle is then inserted, as shown here, as far as the prostatic tissue. The targeted lesion is clearly seen on the sagittal view in this video, and after positioning the access needle, the biopsy is fired, as you see, going exactly through the targeted lesion. This is also checked on the transverse view to ensure good targeting in terms of laterality. Another sample is obtained from the lesion of interest using the biopsy needle. This is also fired in a similar fashion, right in the center of the lesion. This is also checked again on the transverse view. And as you can see, the needle has gone through the lesion. The next biopsy will be taken more medially to ensure adequate distribution of the biopsy cause through the lesion of interest. After satisfactory position of the needle medially, the biopsy needle is fired through the lesion to obtain another satisfactory sample that is also checked on the transverse position to ensure adequacy.
Have you been recently diagnosed with prostate cancer and you are not sure what treatment you should choose? Have you been given multiple choices by your urologist, including surgery, radiotherapy, or just monitoring? Do you feel lost as to what are the pros and cons of each treatment and what is best for you? This video focuses on the results of one of the largest UK randomized trials called the PROTECT trial, comparing 3 different treatment options for confined prostate cancer, including surgery, radiotherapy, and active monitoring. Many urologists in the UK and worldwide use the findings of this study as a reference to advise their patients regarding which option to choose. We will go through the results of the trial and the impact of each option on the odds of dying from prostate cancer or from any other cause, so that you could be better informed when choosing what treatment option to go for. If you're ready to go through the results of the trial, let's dive in. What is the PROTECT trial? Between 1999 and 2009 in the United Kingdom, 1643 men with a diagnosis of a confined prostate cancer were enrolled in a trial to evaluate the effectiveness of different treatment options, with 545 randomly assigned to receive active monitoring. This entailed regular PSA blood tests, with further actions if there were any signs that the cancer is progressing. 553 to undergo prostatectomy, which is a surgical removal of the prostate, and 545 to undergo radiotherapy, which is radiation to eliminate cancer cells. Both surgery and radiotherapy are also called radical treatments. When was the decision for active monitoring reconsidered? If there was an increase of at least 50% in the PSA level during a 12-month period, or any concern on the part of the patient or clinician, the decision for active monitoring is reconsidered, and a review is triggered, with management options that included continued monitoring or radical treatments. What are the main results of this trial? At a median follow-up of 15 years, the results were compared with respect to death from prostate cancer, which was labeled the primary outcome, and death from any cause, metastases, disease progression, and starting hormone treatment. These were all labeled the secondary outcomes. Let's talk first about death from prostate cancer. Overall, there were 45 deaths attributed to prostate cancer over 15 years. 3.1% occurred in the active monitoring group, 2.2% occurred in the prostatectomy group, and 2.9% occurred in the radiotherapy group. There was no significant difference in the rate of death due to prostate cancer among the three groups. The good news was that approximately 97% of patients across the three groups survived prostate cancer 15 years down the line. And as a reminder, these were all cases of prostate cancer that were confined to the prostate. Let's talk about death from any cause. Death from any cause occurred in 356 men, which is around 21.7% of the entire group, and this was evenly distributed between the three groups. The leading causes of death were heart or lung disease in 31.8%, and other cancers in 51.6%. Secondary outcomes. Metastases or distant spread from prostate cancer. The active monitoring group had higher metastasis rates at 9.4%, compared to the prostatectomy group at 4.7% and radiotherapy group at 5%. The need to use hormone treatment. This is often used when the cancer has spread outside the prostate in the active monitoring group, or when there is evidence that it has come back in the surgery or radiotherapy group and no other salvage options are suitable. Long-term therapy with hormones was highest in the active monitoring group at 12.7%, compared to the prostatectomy group at 7.2% and radiotherapy group at 7.7%. Disease progression. There was an increase in the incidence of local progression, which means the disease advancing beyond the confines of the prostate in the active monitoring group at 25.9%, which was remarkably higher than the progression in the prostatectomy group at 10.5%, or the radiotherapy group at 11%. How many patients actually have active treatment with either surgery or radiotherapy? By 15 years, 92.5% of the radiotherapy group and 90.4% of the prostatectomy group underwent treatment, compared to 61.1% of patients in the active monitoring group. 24.4% in the active monitoring received no active treatment or hormone therapy. In other words, these patients spared themselves the side effects of surgery or radiotherapy for 15 years without dying from prostate cancer. What's even more interesting regarding these men who remained on active monitoring for 15 years without any treatment, that at the time of the initial diagnosis, 12.8% of them were considered to have intermediate or high-risk prostate cancer, and 10.5% had Gleason, grade group 2 disease or higher, which is often considered as significant cancer. Metastases or spread outside the prostate in the active monitoring group. The higher incidence of metastatic disease in the active monitoring group at 10 years was anticipated to result in higher deaths of prostate cancer at 15 years. But surprisingly, this was not the case. Among the 40 men in whom metastatic disease had been diagnosed at 10 years, the risk of death from prostate cancer was lower among those in the active monitoring group, 13.6%, than in either the prostatectomy group, 25.0%, or the radiotherapy group, 70.0%. Conclusions. The percentage of patients who survive a diagnosis of confined prostate cancer is high at around 97%, with no significant differences among how the cancer was initially treated, be it monitoring, surgery, or radiotherapy. Active monitoring carries higher risks of metastases and disease progression, but does not impact long-term survival. Radical treatments like surgery or radiotherapy reduce disease progression, but do not improve the percentage of patients who die from prostate cancer compared to active monitoring, which entails offering treatment only when there is evidence of disease progression. Active monitoring offers a less aggressive yet effective management strategy for many, while radical treatments should be reserved for cases with clear indications of higher risk. Enhanced diagnostic precision and long-term follow-up are critical to optimizing outcomes and refining treatment strategies. Therefore, a patient-centered approach, considering individual preferences and balancing treatment harms and benefits, is essential in managing localized prostate cancer. This is the end of the video. In the next video, we will dive into what factors influence the patient's choice of treatment between surgery, radiotherapy, and monitoring for a confined prostate cancer. I hope you enjoyed this video and found it educational. If you did, please consider liking, sharing, and subscribing to the channel to help its growth. See you in the next video.
In this video, we will play a consultation between Richard, who is a 65-year-old patient who was recently diagnosed with prostate cancer, and between his urologist. We will focus on the concept of active surveillance, which implies watching the cancer without treatment. We will discuss who is suitable for this approach and whether it is safe.
We are here to discuss your new cancer diagnosis and treatment options.
Yes, thank you, doctor.
First, I am sorry to learn that you have been diagnosed with a Gleason 6 prostate cancer, which is also now classified as a grade group 1, and we will discuss how to manage this today. I am happy to take any questions from you first, and then we could dive deeply into the answers.
Okay, thank you, doctor. What is a grade group and how many grade are there for prostate cancer?
A grade group is a measure of how aggressive the cancer cells are. Overall, there are 5 grades of prostate cancer. Grade 1 is the lowest and least aggressive grade, and grade 5 is the most aggressive as shown in this table.
Okay, doctor, what is the Gleason score of 6 then, and why there are 2 classifications?
The Gleason score is an overall number that is made of adding 2 numbers together. The first number represents the grade of the most common type of cancer cells in the sampled tissue that is examined under the microscope, and the second number represents the grade of the second most common type, and by combining both numbers, you get the overall Gleason score. This system was developed by Dr. Donald Gleason in the 1960s. He based the grades on how abnormal the cancer cells look compared to normal prostate cells. So for grade 1, the cells look almost like normal prostate cells, and for grade 5, the cells look very different from normal prostate cells as shown here. Grade 1 and 2 are considered benign, and grade 3 or above are considered malignant. The grade group has now replaced the Gleason grade, as doctors think the grade group is a more accurate way to grade prostate cancer cells. This table shows the comparison between Gleason score and the grade groups.
Okay, thank you, doctor. This is very informative, and I now understand that my Gleason score 6 means grade group 1 prostate cancer. Now, I am interested in knowing what treatment options I have and whether it is okay to just watch the cancer.
Certainly, Richard. Your cancer is a grade group 1, which is considered a low-risk prostate cancer, and in those cases, you have many treatment options, including active surveillance, surgery, or radiotherapy. Overall, I strongly recommend active surveillance in your case.
Okay, thank you, doctor. What is active surveillance?
Active surveillance entails watching your cancer closely with the aim of offering treatment and curing the cancer if there are any signs of progression in the future. But until then, we aim to delay the treatment as much as possible to spare you the side effects of surgery or radiotherapy.
Okay, how is active surveillance done?
There are many active surveillance protocols, but most involve doing a regular PSA blood test, for example 3 monthly, as well as a regular MRI scans of the prostate, usually yearly, as well as a repeat prostate biopsy after 1 year of the initial diagnosis and 3 yearly thereafter to ensure that the cancer cells are not becoming more aggressive or the volume of cancer is not becoming larger.
Okay, doctor, I like the idea of active surveillance, but I am concerned that the cancer might spread while I am on surveillance. Is it safe to just watch the cancer without any treatment?
This is very understandable and does drive many patients on active surveillance to choose radical treatment like surgery or radiotherapy due to the anxiety that active surveillance causes them. There is a large amount of evidence in the literature regarding the safety of active surveillance. This includes a large Canadian cohort study where 993 men with low or intermediate risk prostate cancer were followed up for around 15 years. There were 15 deaths, 1.5%, from prostate cancer. The 10 and 15-year cause-specific survival rates were 98.1% and 94.3%, respectively. An additional 13 patients, 1.3%, developed metastatic disease. At 5, 10, and 15 years, 75.7%, 63.5%, and 55.0% of patients remained untreated and on surveillance. This shows that the majority of patients who chose surveillance remained on active surveillance 15 years down the line.
These data are very encouraging, doctor, and it shows me that active surveillance seems to be safe for low-risk prostate cancers like mine. Are there any other studies comparing active surveillance with radical treatment?
Yes, there are some trials and studies comparing surveillance with radical treatment. The available data suggest that outcomes in appropriately selected males with localized prostate cancer who are managed with initial observation appear to be similar to those undergoing immediate definitive therapy. The best evidence in support of us comes from the PIVOT trial, for which long-term results are available. This study randomly assigned 731 males with localized prostate cancer to upfront radical prostatectomy, which is surgery to remove the whole prostate, versus delayed initial treatment, and reported that after 22 years of follow-up, surgery had only a very small impact on reducing death from any cause. The cancer mean survival in the surgery group was 13.6 versus 12.6 years in the delayed treatment group. When the analysis was restricted to males with low-risk disease, the benefit of surgery was much smaller, with no appreciable difference in mortality between those who had surgery and those who were initially observed. Notably, the risk of dying from a non-prostate cancer cause in PIVOT was higher than in many other prostate cancer studies, and because of this, the results should be interpreted with caution because they may not reflect outcomes in a healthy population.
Okay, thank you, doctor. I am more and more convinced that surveillance is the right strategy for me. I have heard of the PROTECT trial, which was conducted in the UK. Could the data from that trial apply to me?
Yes, this could be applied to you to some extent, but the patients in the PROTECT trial were monitored less stringently than patients who are put on active surveillance, and therefore the results should be interpreted with caution. The PROTECT trial randomly assigned over 1,600 males to active monitoring, surgery, or radiation. In this trial, there were only a limited number of prostate cancer-related deaths in any of the groups, and there was no significant difference in the 15-year cancer-specific survival or all-cause mortality among the three treatments. The development of metastases was significantly more frequent in patients managed with active monitoring. However, it is likely that these results were driven by the over 20% of males with intermediate to high-risk disease who were randomized to the observation arm. Unfortunately, the PROTECT trial was not powered appropriately for subgroup analyses, so a focused evaluation of low-risk patients was not possible. But you could perhaps infer the outcome for low-risk cases like yours. If the mortality for a higher-risk group in the monitoring arm was similar to surgery or radiotherapy, you would expect at least the same for low-risk patients like yourselves.
Thank you, doctor. This is very helpful. What if my cancer was more aggressive than grade group 1? Would I still be eligible for active surveillance?
Active surveillance could be offered to a selected patients with grade group 2 disease. For example, if they have less than 10% pattern 4 on the Gleason grading, and if the prostate-specific antigen, PSA, was less than 10 nanogram per milliliter, and they have low disease extent on imaging and low extent of tumor in the biopsies, less than or equal to 3 positive cores with Gleason score 3+4, and less than or equal to 50% cancer involvement per core. People who go on surveillance with higher grade group accept the potential increased risk of metastatic progression. Patients with grade group 3 disease should be excluded from active surveillance protocols.
Thank you, Doctor. I am now very clear on what active surveillance entails, its safety, and the required tests needed to assure me that I am on the right track as time goes by.
You are welcome. I will request for you to have a PSA blood test every 3 months for the next year, an MRI scan in 1 year, and I will give you a call in 3 months' time after your next PSA to see how you are getting on.
Thank you, Doctor. I feel well looked after and happy with this approach.
Natural treatments for prostate health, a comprehensive evidence-based review. Several natural products have been studied for their potential benefits in treating or preventing prostate issues, including chronic prostatitis, chronic pelvic pain syndrome, and prostate cancer. Here's what we know. 1. Pollen Extract, what it is. A natural supplement made from pollen, containing vitamins, amino acids, and other compounds. Benefits. It can help reduce inflammation, pain, and improve quality of life for people with chronic prostate problems. It has shown promise in treating symptoms like pain and discomfort without serious side effects. Prostate cancer. Studies suggest it may help slow the growth of prostate cancer cells, especially in cases where hormones are less effective. 2. Beta-Sitosterol, what it is. A plant compound found in foods like soy, peanuts, and saw palmetto. Benefits. It helps improve urinary symptoms, like frequent urination, which is common in prostate conditions like benign prostatic hyperplasia, BPH. It works by affecting hormones, but doesn't shrink the prostate. Side effects. Generally, it's safe, but some people may experience mild stomach issues. 3. Palmitoylethanolamide, PEA, what it is. A natural fatty acid compound that helps with pain and inflammation. Benefits. It has been used to manage chronic pain, including pelvic and prostate-related pain. How it works. It helps reduce pain by affecting nerve cells and has anti-inflammatory effects. 4. Pomegranate, what it is. A fruit rich in antioxidants, particularly in L-glutamines. Benefits. Some early studies showed that pomegranate could slow down the growth of prostate cancer by delaying the increase in PSA, a marker of prostate cancer. However, more recent studies have not confirmed these findings. Current evidence. It may help a little, but more research is needed. 5. Soy and flaxseed, what they are. Foods containing plant-based compounds that act like estrogen in the body, phytoestrogens. Benefits. There's some evidence that these may help reduce prostate cancer risk, but the results are mixed. For soy, the evidence isn't clear. Flaxseed, however, may offer some protection, especially with higher levels of a compound called enterolactone found in the body. Challenges with natural treatments, quality and dosage. The quality of these natural products can vary a lot, and the right amount to use isn't always clear. Inconsistent results. Studies don't always agree on whether these treatments work, partly because how the treatments are prepared and taken can be different from study to study. What's needed? More research is needed to confirm how well these natural treatments work and to figure out the best way to use them safely. In conclusion, some natural treatments like pollen extract, beta-sitosterol, and pomegranate show potential, but more studies are needed to make firm conclusions. Always consult with a healthcare provider before trying new supplements or treatments. In this video, we present a structured approach to address the risks of impotence following a prostatectomy, particularly when nerve-sparing techniques are considered.
1. Before surgery risk understanding. Nerve-sparing surgery can help preserve erectile function, but it's not always possible. The risk of erectile dysfunction is about 50% with one nerve spared and over 60% if both are sacrificed. Imaging. A detailed MRI can help surgeons decide whether nerves can be preserved. Advanced techniques. Some surgeons use the NeuroSafe method during surgery to check tissue and make real-time decisions about nerve preservation. 2. After surgery medications. Start a PDE5 inhibitor, like Viagra, 6 weeks after surgery, or possibly earlier for better outcomes. Other treatments. Options include injections or urethral suppositories, for example, prostaglandin E1, vacuum devices to maintain blood flow and prevent shrinkage while waiting for recovery. Specialist support. Follow-up in a specialist ED clinic is essential for personalized care. 3. When nerve sparing isn't possible. Nerves may need to be sacrificed in cases of advanced or aggressive cancer.
Urinary incontinence after prostate surgery. Up to 50% of patients may experience mild urinary leakage after surgery, which usually improves over 12 to 18 months. Around 5 to 10% of patients may have severe, long-term leakage that requires using more than one pad daily. Treatment for severe incontinence. If severe leakage continues after 12 months, treatments like injections, slings, or an artificial urinary sphincter may be considered. The artificial urinary sphincter is the most effective option, with an 80% success rate. Other possible causes of leakage. Problems like bladder scarring or overactive bladder muscles can also cause leakage. These need special tests before deciding on treatments.
Have you heard of turmeric, a carrot-looking plant? Are you wondering if it might help fight prostate cancer? In this video, we study the latest evidence for its effectiveness against prostate cancer with shockingly positive results. We will use the term curcumin mostly, which is the active ingredient in turmeric, throughout this video. The information presented in this video are based on the latest available evidence. What does curcumin do? 1. Stops cancer cells from growing and spreading. In lab studies, curcumin slows down the growth of prostate cancer cells, prevents them from spreading, and even stops them from sticking to other tissues. 2. Kills cancer cells naturally. It helps trigger the body's natural cell-killing processes, making it easier for your body to get rid of cancer cells. It blocks proteins that cancer cells use to survive and grow. 3. Disrupts cancer support systems. Curcumin cuts off the signals cancer cells use to grow and divide. What about animal studies? In studies with mice, curcumin slowed down tumor growth, reduced the size of tumors, increased the death of cancer cells, stopped cancer from spreading by cutting off its ability to grow new blood vessels. Why is curcumin promising? Low toxicity. It's gentle on the body compared to many cancer treatments. Wide effects. Works on multiple fronts to stop cancer in its tracks. Natural source. Found in a common spice, turmeric, making it an easily accessible compound. What's next? Human trials. Clinical studies are essential to see if curcumin works effectively in people with prostate cancer. The bottom line, curcumin, found in turmeric, shows potential as a natural way to slow down prostate cancer and support existing treatments. While more research is needed, it's an exciting step toward gentler, more effective cancer therapies. Understanding PSA, what you need to know. PSA stands for prostate-specific antigen, a protein produced by the cells of the prostate gland. While PSA levels can fluctuate due to factors like age and prostate size, understanding what is considered normal can provide valuable insights into your prostate health. But what exactly is a normal PSA level? Is there a specific number you should aim for? Did you know PSA testing has a controversial history? Let's explore the origins, significance, and controversies surrounding PSA testing, helping you make informed decisions about your health. Let's dive in. The origins of PSA testing. The story of the PSA test begins in the 1970s, when researchers sought ways to detect and monitor prostate cancer. PSA, a protein produced by the prostate gland, was first discovered by Dr. T. Ming Chu at Roswell Park Memorial Institute in Buffalo, New York, in 1970. However, it wasn't until the mid-1980s that PSA's potential as a diagnostic tool was fully recognized. By the late 1980s, PSA testing became widespread in the US and other countries, leading to earlier detection of prostate cancer. While the test has undoubtedly saved lives by identifying prostate cancer in its early stages, it has also been linked to overdiagnosis and overtreatment of indolent tumors that may never cause harm. This duality has sparked ongoing debates about its appropriate use. Why is PSA testing controversial? The controversy surrounding PSA testing stems from its complex implications. PSA testing, often recommended for men over 50, serves as an early warning system for potential prostate issues. However, the evolving understanding of prostate cancer has revealed that not all detected cancers require immediate treatment. Indolent forms of prostate cancer may grow so slowly that they pose little to no threat during a man's lifetime. This has led to concerns about overdiagnosis and unnecessary treatments, which can result in invasive procedures, emotional stress, and potential side effects. Physicians may feel compelled to act on elevated PSA levels, even when more comprehensive evaluations, like biopsies or scans, could suggest a more measured approach. The debate underscores the importance of shared decision-making between patients and healthcare providers, considering individual risk factors and preferences to navigate this nuanced issue. What is the normal PSA level? In men without prostate cancer, a PSA level below 4.0 nanograms per milliliter is generally considered normal. However, this threshold is not absolute. Some men with PSA levels below 4.0 nanograms per milliliter may have prostate cancer. Conversely, others with higher PSA levels may not. Discussions around optimal PSA thresholds are ongoing. For instance, a 2004 study published in the New England Journal of Medicine suggested lowering the threshold to 2.5 nanograms per milliliter, which could detect more cases of prostate cancer earlier. However, this approach might also lead to higher rates of false positives and unnecessary biopsies. Making informed choices about PSA testing. PSA testing remains a valuable tool in monitoring prostate health, but its interpretation requires a nuanced approach. While it can aid in early cancer detection, the risks of overdiagnosis and overtreatment highlight the importance of individualized care and informed decision-making. By considering factors like age, ethnicity, personal health, and family history, you and your healthcare provider can determine the best course of action for your specific needs. Thank you for watching. If you found this information helpful, don't forget to like, comment, and share. Your engagement helps us continue creating content that empowers you to take charge of your health.